good afternoon or morning, wherever your geography may have you. Welcome to the October 2025 Quarterly Arkansas All-Payer Claims Database, APCD, Data Users Group. This is our 25th session. Quick check, is everyone able to see the cover slide on the screen? Yes? Okay. And you're able to hear me? Yes? Okay, yeah. Thank you. Well, I'm Kenley Money. I'm with the Arkansas Center for Health Improvement, ACHI for short, and I manage the team administering the data assets in the Arkansas Healthcare Transparency Initiative called ACHI, which includes the All-Payer Claims Database. Today's agenda was developed using data user input. If you have ideas about topics, please let us know, either by entering ideas, questions in the chat, or by emailing us. Maybe they'll be on a future agenda for the data users group. Today, the introduction, of course, but our topics include methods and considerations when using pharmacy claims from the Arkansas APCD, member enrollment selection table enhancement, the short name is MEST, and latest APCD release information and data tips, and of course, questions and discussion should time allow. I encourage all of you to put questions in the chat along the way, and we'll watch it as we go and address them as we can. All right. Our team today the speakers today are me, I've introduced myself, and Sarah Crawford, Senior Data Analyst at ACHI. Some housekeeping rules before we move forward. Feel free, like I said before, to type your questions in the chat. We'll get them as we can. At the end of today's session, we'll provide a link to our service desk application where you can enter any question or topic you're interested in discussing, whether it's about today's presentation or something else. Say at the end of today's session, we will do our best to get it out this afternoon, maybe in the morning, depending upon the time it takes to capture the recording and prepare the slides, etc. Most of you will agree with this if you've used our data. The APCD data can be complicated. You can also request time with our team to address specific questions you may have about how to use or interpret the data. The link that will be provided in the follow-up email can be used to request that time. That said, a quick reminder, webinar recordings and presentation material from the past data users group sessions are available at arkansasapcd.net. If we did not address a question you have today, you might look at some older data users groups decks and the answer might be there. And then finally, the next data users group is in January 2026. Oh goodness. We hope that you find today's session helpful. Part of the introduction is just a quick overview of ACHI and the Healthcare Transparency Initiative. If there's anybody new on the phone, this might help provide some foundational context. The Arkansas Center for Health Improvement, ACHI, was established in 1998, creating a much-needed intersection between research and policy. We're a nonpartisan, independent health policy center dedicated to improving the health of Arkansans with proven experience in the management integration of health data. We're administratively housed under UAMS, but have developed partnerships with state agencies and institutions across Arkansas and the country. Our mission, vision, and values stated here. It's worth a quick chat about it. The ACHI's, and it's summed up, I think, primarily in this mission statement. ACHI's mission is to be a catalyst for improving the health of Arkansans through evidence-based research, public issue advocacy, and collaborative program development. And that focus led us to work with the Arkansas Healthcare Transparency Initiative. Act 1233 of 2015 created the HTI, which has become the premier resource for administrative health data available to research, for research and analysis. Boy, I'll slow down, in the state. Where does ACHI come into this? Well, when the HTI was formed in 2015, the authority was named as the Arkansas Insurance Department. They are in charge of rules, regulations. They sign the data use agreements, they manage the money. ACHI is the administrator. We manage the data assets. We are, for all intents and purposes, the vendor for the Healthcare Transparency Initiative data. And we're also one of the primary users of it for research and analysis. So that's how we fit into this picture. The HTI can be used for many things, and these 3 bullets hardly do it justice. These are some of the big hitters that our data users have focused upon. But it's important to this second bullet here, HTI data assets include the APCD, which is the subject primarily of today. But with that APCD, we also have linked non-claims-based data, birth certificates, death certificates, cancer registry data, some hospital discharge and ED emergency department data, workers' compensation data, and medical marijuana card holder data. The importance of this is that there are 26 APCDs in the country, and I would go out on a limb and say Arkansas is the only one that has integrated these non-claims-based data into an APCD type solution without additional overhead. Meaning, in another state, if you wanted to merge birth certificate data with your claims data, you would have to make 2 data requests, one to the managing agency of the birth certificate data, and then another to the APCD. But for Arkansas, under the Healthcare Transparency Initiative, it's all one process because it's merged together. So we're going to move to our featured topic, methods and considerations when using pharmacy claims from the Arkansas APCD. Today's speaker is Sarah Crawford. She's a senior data analyst at ACHI. She has spoken with us before on dental data, and today she shares useful methodologies to work with pharmacy data, which is arguably the most challenging and nuanced claims data there is. She'll be running her own slides, so I'm going to stop sharing and she can display her slides. Welcome, Sarah.
Hi. Okay. My computer actually just gave me a blue screen of death. So
no, then let me share. Because I have your
share because I ran into Nicole's office and I was
like, no, okay, stand by.
Sorry, guys.
Oh man, with yesterday and all the outages, good gosh.
Yeah, it was like.
All right. So do you
let's restart? And I was like,
do you have? Is it okay if I leave? Do you have the necessary information?
Yes.
Okay.
My stuff. So that's
you fine. Just say next slide and I will proceed.
So sorry about this. Okay. So as Kelly said, my name's Sarah Crawford. I'm in Nicole's office. So I'm a senior data analyst here at ACHI. And I want to talk to you about some things to consider when you're developing a study design that involves the evaluation of pharmacy claims in the Arkansas APCD. Next slide. I'm going to pull this over here.
Is that right?
There we go. I don't know where your keyboard is, Nicole. Okay. Pharmacy claims are often more difficult to work with than medical claims are. There's a couple of main issues that are encountered when working with pharmacy projects, and I'm going to share one of the biggest ones here with you today. Many pharmacy insurers use third-party insurance companies that manage their prescription drug benefits for them. These are third-party administrators, or TPAs, and then pharmacy benefit managers, or PBMs, are a subset of those. Since all insurers that are covering 2,000 or more lives are required to report to the APCD, this results in both the original insurer and the third party that they are using both reporting their members and submitting claims for them. Insurers' use of PBMs and or TPAs ultimately results in multiple claims submitted by different submitters for the same pharmacy prescription fill. And this can really mess up your results if it's not considered and accommodated for. And it does require some pre-planning and adjustments to be made when you are using the pharmacy claims and their associated member records. Next slide, please. So currently, there is not a marker on a member record that flags it as a PBM, although this may be changing in the next DSG that is currently being updated. It can also be difficult to determine with precision who a PBM or TPA is submitting for. The PBMs and TPAs are an issue when an insurer uses them. Oftentimes, they will submit a claim and the insurer themselves will also submit a claim for the same thing. So they're both submitting some of the same information, but not necessarily all of the same information. Some submitters will have more complete information than the other. But this will result in 2 or more claim lines for the same prescription fill on different member IDs for the same person or study ID on the same day at the same pharmacy. So when this happens, depending on what you are trying to find or count, you may not want to keep those duplicate records. This also happens with Medicare fee-for-service and Medicare Part D claims as well. Claims for the same fill will sometimes be submitted by the Part D submitter and then again by Medicare fee-for-service. So if you are using ResDAG Medicare claims as well for your project, this issue will be present between those 2 payer types as well. Next slide, please. Sometimes both the PBM and the insurer will submit the same information all the way across the claim line. But as I said, oftentimes one will have more complete information. The examples that I have here are pretty similar in these fields, but not exactly the same. One of them may also have a lot of missing information in other relevant fields that you do want information on for your study, such as like the prescribing provider information or the pharmacy specific information. Next slide. So duplicate claims, however, are not always a problem that needs to be remedied. Some are legitimate. A person could have different pharmacy plans at the same time, one being secondary to another. In this example, Medicaid is probably a secondary plan to this other submitter. This is one reason why it's not recommended to blindly deduplicate all duplicate prescription fills. Doing so would eliminate claim lines that are accurate and needed. Next slide. Medicaid will often submit information in a duplicate claim on individuals covered in a PASS. PASSes are provider-led Arkansas shared savings entities, and they are a Medicaid managed program for individuals with complex behavioral health, intellectual disability, or developmental disability needs. So the PASS is administered by a private managed care organization, and these organizations report claims, and Medicaid will also report claims for the same fill events. This example I have here shows an individual who is covered by a PASS, but the PASS is using a PBM, which is also submitting a claim. And then Medicaid is also submitted one. So this one has 3 claims for the same fill. And notice how not all the fields match here. These are the type of situations you will come across that will require you to use your knowledge of the submitters and payer types in question in order to make the best decisions for your project. Next slide. So like I said before, if you're going to want to do any reporting regarding payer type, like how many distinct people are filling a certain type of prescription by payer type, or average spend per payer type, or anything like that, that will be broken out in that way, you'll need to do some plan coverage type reassignment. We saw in some of our examples earlier that PBMs are used by lots of different payer types, and just as a reminder, when looking at this slide, QHPs are qualified health plans offered on the marketplace. Medicaid QHPs are marketplace plans that Medicaid purchases for members who qualify. And then Medicare Part D plans are those plans that individuals with Medicare may purchase either as a supplement to their fee-for-service plan or as part of a Medicare Advantage plan. And then EBD is Employee Benefits Division Plans for state and public school employees. And all of these may at times use PBMs. Because of this, whatever category you assign to the various PBMs, whether it's commercial or something else, is probably going to need to be changed depending on what plan the PBM is submitting for. So prior to any amendments being done on the claim side to rectify duplicate fills, those PBMs need to be reassigned according to the plan type for which they are covering, so that any associated prescription fills or payments on them are assigned correctly. I included here part of the example from the previous slide. Depending on what else is on those claim lines, you may find that, for example, the one that is currently labeled commercial, COM, has the most accurate and complete information on it. That's Caremark. It's a PBM claim. So if we are going to keep it, we'd want to have the payer type assignment of pass on it, since that is what it's actually representing here. We find that doing that reassignment up front when possible is easiest once moving on to working with the claims, because it helps you to figure out what you're actually looking at. Next slide. So those are the main issues that need to be considered when developing your study plan, but what can we do about them? If you have decided that you are interested in differences between payer types at all for your study, then you'll likely want known payer type reassignment to be your first step in the process. ACHI does have a method for doing this reassignment of the payer type in the member table that we will be talking about. Doing this first will give you the best possible results when you go to do your claims deduplication. ACHI uses a case-by-case deduplication method for pharmacy claims. Now, by that I don't mean like claim line by claim line deduping, but like payer type submitter group by payer type submitter group deduping. So for each project for each year, we go through group by group to determine which submitter is providing the best information for what we need, and we choose which payer's claim to remove for that particular group. And this can be kind of hard to conceptualize with me just talking about it, so I'm going to go through some more specifics and some examples on our method in just a second. Next slide. So you do not need to reassign payer types and dedupe claims for every project that pharmacy claims are used for. Nobody wants to do work that isn't necessary. So to be the most efficient with your time, let's talk a little bit about how to decide when it is appropriate to do so. Your decision is going to depend on what the outcomes are that you're interested in for your project. It's best to think about your deduping strategy when you start planning your project. Things that you'll need to consider should include: what are you planning on counting? Are you counting people, prescriptions, events, trips to the pharmacy, prescription days or amounts? Consider both your numerators and your denominators. Think about how you're going to be counting these things. Will duplicate claims matter when you're doing your counting? Do you need to know anything about expenditures? Deduping is going to be very important if you do. If you're wanting to show differences between payer types, then obviously you'll need to do some type of payer reassignment. Next slide. Since payer type reassignment is done first, when both reassignment and deduping need to be done, I'm going to talk about the methods for that first. I want to give you a basic method for planned payer type reassignment for these PBMs or TPAs that are submitting claims on behalf of other insurers. It's going to be a pretty high level description of this method, but you can use this information to help you think about what might be the best method for your particular project. As we've been discussing, this focuses on the member records that have been pulled for plans that cover pharmacy. At ACHI, we always pull member records by year and recommend that if your time period of interest is more than 1 year, that you pull members by each year rather than all at once. So when we pull member records, we also assign starting plan types like Medicaid, Medicare Advantage, commercial, etc. If you do need help doing this assignment, the data team has a document that describes how to identify different payer types, and they keep that updated and available online in the data tips. And I put a link to that here, and you'll have access to this presentation after today if you need it later. After that, the first thing that we do would be rolling up our enrollment segment within submitters, so that eventually we have one record per continuous time period per member ID. To do this, we eliminate fields that aren't necessary, just keeping what is needed to get those complete segments. Then we would find either complete or near complete overlapping enrollment segments between known PBMs, TPAs, and other plans within a study ID, so within a person, and we'd relabel the PBM or TPA to match the main pharmacy coverage type that it's matched up with. I listed out here some known PBM submitters, but know that these can change, and some years will have some of these, but not others, and then new ones could appear moving forward as well. So with the knowledge that we have, we can reassign those that we know appropriately. For example, we know 99CAR1 is Caremark, so if there's an overlap with one of the study IDs, other pharmacy plans, we can usually assume that it's a PBM for that plan and reassign it. Next slide. So as you're going through this, you probably will find overlaps for submitters that you hadn't previously considered. These you'll need to look into specifically, taking into consideration the year that you're looking at and whether you want those plans, or whether those plans make sense as plans that people could legitimately have together, or if they're likely either a PBM or TPA for another plan. There may be some that you're still unsure about, and these ones you might want to record and hold off on reassignment to see how they end up overlapping in the claims. And then if they are an issue in the claims, then you can reassign them if necessary during that process. This is going to take some judgment calls, and each project will likely end up a little bit different depending on what you're interested in and what the time period of interest is. Don't expect perfection. When you go through this, you'll need to decide where your comfort level lies and do the best you can to reassign the groups with the largest overlaps with the knowledge that you have regarding the submitters in question. Remember that you can gain knowledge about the submitters, again, by using those data tips online. Next slide. Now let's talk about some methods for deduping pharmacy fills. At this point in your program, you may already have reassigned your members to appropriate payer types if you needed to. So now you're ready to pull your pharmacy claims for your members of interest. And this should be only using the SEIDs or submitting entity ID from your denominator member table that you already created. I just want to remind you quickly, when I refer to SEID, that's going to be the submitter and member ID concatenated. So those variables are on both the member records and the claims. They're ME001 and ME107 on the member table, and then on the pharmacy claims, they're PC001 and PC107. Once you have all of your claims for your population of interest, you can join those results to your member table and bring in only your assigned study IDs and payer types into that claims file. The study ID can only be made with the variables in the member record, which is why it needs to be created there and brought into the claims. So study ID is going to be your APCD unique ID, which is ME998, concatenated with the member's gender, which is ME013. When counting distinct people, that study ID is what you're actually be counting. These will both be important as you go through the claims deduplication process. So those two variables, the study ID and your payer type, do need to be brought in for that. Next slide, please. So now that you have all your claims ready, you can create a new variable in that file combining submitter and payer type. And this is what ACHI uses to check to see what submitter payer type combos are coming up as duplicates. So you need both of these together in one variable to know exactly what type of member record the claim goes with. I wanted to show you some kind of an example of what variables you would have at this point if you were going through the process. This is a table I just created. The information isn't real, but you can see highlighted here that submitter payer variable that I just mentioned. You would still want to have your other claim variables of interest here too, like the payment variables or information about the pharmacy, so that you can see what submitters are submitting and have more complete information for those variables that you are most interested in. Next slide. To identify duplicate fills in your file, we'd want to find claim lines where there are different SEIDs on claims with the same study ID, NPI number for the pharmacy, fill date, and drug code. So we concatenate those into one variable that we call dupe ID to make looking for those duplicates easier. You see that dupe ID highlighted in this example. Once you have those variables assigned, you can then group by that dupe ID and count your SEIDs with each dupe ID. So any dupe ID with more than one SEID should be examined as a potential duplicate fill. Next slide, please. Then for those where there is duplicates, we create another variable that concatenates the two or more submitter pairs that are associated with a duplicate claim submission. And we call this variable submitter combo. Then you can count the number of times this particular submitter combo appears in the duplicate claims to see how big of an issue this combination is. For example, you may find that this Caremark and standard QHP with a certain submitter are your top combination for duplicate claims. And this might tell you that this submitter is using Caremark as their PBM for these particular plans. And that they should probably be deduped. But before you do that, make sure you look at the actual claims. In this example here, that first line is Caremark, but the payer type has been changed to QHP by the process that I had previously described. The new fields of submitter payer, dupe ID, and submitter combo are there as well. And you can see that they have the same dupe ID, and the submitter combo field is what you will use to group by to count dupe IDs with that combination to see which ones are having the biggest impact on your particular data set and what ones you should focus on potentially deduping first. Next slide, please. From there, at ACHI, we would go through each submitter combo one at a time to think about if deduping is needed for the group, and if so, which submitter to remove when they are in this combination. So in order to start this, we typically will look at the submitter combo group with the most duplicate claims first, and then go down the list one by one. The first thing to do once you identify which submitter combo to examine is to look at a handful of those duplicate claims. And by that I mean opening up that table and looking at the actual claim lines. The reason it's so important to look at the claims before deduping a certain submitter group is twofold. One, you want to make sure that these look like they are actually duplicate claims worthy of deduping, and not just people who have coverage by two separate plans. Think about what makes sense here based on what you know about the submitters. Second, if you decide that yes, you should eliminate one of these claim lines based on it being a duplicate of the other, you'll want to look at what information is being provided by each submitter. As we said, it's not always exactly the same. Make sure you look at them to make an educated decision on which to remove based on what you need to know about the claim for your study. Once you have decided, if the payer type has already been amended as needed, you may remove the claim lines for that first combo of the submitter that you chose when in that duplicate claim group. If the payer type hasn't been amended, if you are planning on keeping the line for, say, the PBM, you'll first want to adjust the payer type on those claim lines prior to deduping out the insurer's claim. Then you can run your macro again, looking for what combinations remain, and move on to the next. Next slide. When ACHI goes through this process, we typically will keep a record of how many duplicate claims we're finding of each submitter combo and what submitters' claims we are removing from that combo, so that we can go back and see what we did if we have any questions later on. So I'm providing an amended example from a project we did a while ago. This doesn't need to be fancy. You're just trying to keep some kind of record of what you're doing. What you're seeing here is every 3 columns is 1 round of deduping. There's the submitter combo, or the set of submitters and the duplicate claims being counted. Then the claims column is the number of claims that are duplicates of another in that same combination. And then the third column is which of those submitters we removed for that round. Then the next set of 3 columns is the same thing for the next round. So for the first round here, we examined claims in that 80799 Caremark combo, because that is the combination that we had the most duplicates for, and we decided to remove the Caremark claims. For the next round, we see that the top combo is actually a triple combo. Those past Caremark Medicaid ones, we looked at an example of that earlier. But if you look 3 down, the third one from the top is just Medicaid in the same pass. And then a couple down from that, you see just the Caremark PBM in the pass. So after review, we removed Medicaid when there was a 99 MCD1 Medicaid duped with a 16244 pass. So that took out that third line there. And it also took out the Medicaid lines that contributed to the triple duplication in the first line. So now in the third round, those from the triple that were at the top of the second one, the Caremark and the pass still remain, and they are joined there by the 100,000 or so that were already just Caremark and 16244 pass. So you can see the number there changed because the Medicaid lines are no longer in there, and the 100,000 ones from before were added, and so forth. So this spreadsheet would just kind of continue on going through each round. There's a set of 3 columns for each decision made, and then we can follow that deduplication trail later. Next slide. I know I've said this a few times throughout, but remember when you're doing this that you are not seeking perfection and that there are no duplicate lines left. Some do not need to be deduped. Some are relevant, some are accurate. You do not want to just blindly deduplicate all duplicate claim lines in a claims pool. For example, dual enrolled individuals in Medicare and Medicaid will often have duplicate claims in pharmacy, but both of those need to be kept. Also, if your study period is longer than a year, deduping should be done for each year by itself. The PBMs and TPAs change over time, and in order for you to get the best results, claims should be examined within a limited time period. Always look at the claims themselves before removing any claim lines. There's always going to be some error in this method, but you're trying to get as close to accurate information as possible, working within what you specifically need for your project or study question. Next slide. I want to mention here that when you are going through deduplicating the claims, when looking at Medicaid duplicate fills, there are some things to consider when you're deciding if you need to keep them. Medicaid itself doesn't use a PBM and never has, so claims with 99 MCD1 as the submitter, if they're matched with a PBM claim, then that PBM should be assumed to belong to another plan, either a PASS, a Medicaid QHP, or some other commercial plan that's using a PBM. With PASS and Medicaid QHP, those are plans that Medicaid still keeps record on since they are Medicaid plans. So Medicaid might submit a duplicate claim as part of their record keeping, even though they aren't the ones paying. So those Medicaid claim lines could be removed. But with other plan types, those Medicaid submissions could be a supplemental plan. Individuals may have EBD in Medicaid or a QHP or commercial plan in Medicaid. I just wanted to point out that Medicaid, that 99 MCD1, is kind of a special case. And this is the kind of thing I'm talking about when I've been saying, like, you need to use your subject matter knowledge when going through each group and thinking about your deduping. Next slide. Okay, so after going through all that, I wanted to do a little like test project of scenarios so you guys can kind of see when you might want to consider deduping claims and or reassigning payer types. And when going through all that won't actually be necessary for your project. And you can come back to reference these later when you are going through trying to figure out if you need to do this, and I think it could be helpful. So what if your study asks how many days distinct individuals went to pick up prescriptions at a pharmacy? So you're taking account of events per person. So you would not need to dedupe or reassign those ones. So the next question is how many different types of prescription drugs a person filled in a year? So you are counting drug codes, either NDCs or Metaspan categories by person. So you would not need to dedupe or reassign in that case. You can go to the next one. If your study asks you to determine the expenditures per fill of a certain drug by payer type, you're looking for the variation of total amount spent per fill of a certain drug by payer type. So you would need to dedupe claims in order to get closest to the expenditure estimates. And you would also need to reassign those PBMs to the primary pharmacy coverage category. If your study question asks how many times a particular prescription drug was filled per distinct person, you're looking for a count of distinct fills per drug per person. So you would not need to dedupe or reassign. Next one. If your study question is how many different types of drugs were filled per distinct person per year by payer type, so you're looking for the variation of the number of drug categories by person and payer type, you would need to reassign payer type there, and you would not need to dedupe claims. If you were asking how many days a person had a certain type of drug available to them, so you're looking for a count of supply days per person, you would need to dedupe claims and you would not need to reassign payer type. Okay, next one. So just as a reminder, I know Kenley says this all the time too, when working on any project, make sure you refer to the data tips on special considerations with certain submitters' member IDs and different time periods and different versions of the APCD. With pharmacy specifically, there are a couple of changes that need to be made for Cigna's and Caremark's member IDs in both the member table and the claims table that I believe are still active, and I have that information on this slide here for you. Next slide. So there's also a newly discovered issue with the newest PBM for EBD, which is 99NAV1. And that they incorrectly submitted PC021, which is the pharmacy NPI that we use in the deduplication method for the claims. And they submitted it as the same as the prescriber's NPI. We know that EBD does often have legitimate duplicate fills with Medicaid, but the normal method won't work to pick up these 2024 currently because of this error in their data. In previous years, when they used other PBMs, we saw lots of these kinds of overlaps in the claims. So when we didn't see any in 2024, that's how we knew that something was up and could look and identify the issue. So have you ever come across these kinds of things when you're working with the APC where something like doesn't really make sense? Check your data tips first. And then if you don't see anything on it there, please email us and let the team know about the problem so that we can look into it and see if there's a way to remedy the problem. And that's all I have for you today. These slides, as well as my notes on them, will be available soon after this meeting, and we always put them up. So you can reference them in the future if you decide to go ahead and do a project using pharmacy claims. But I'd be happy to take any questions if somebody had some.
There is a question in the chat.
Okay, let's see.
Ron Akins, he says, I'm currently exploring potential data sources for my practicum and had a question about academic access. Could you share with the process and timeline? Okay, this is about data requests. So Sarah, I will take this one. All right. This is a great question, and it should probably be a standard slide in all of our data users groups. The about data requests. So we'll divert just for about 45 seconds to talk about that. If you are a student at UAMS in the College of Public Health, any student or faculty at UAMS, you have access to a copy of the Arkansas APCD and all of its other data sources under the Healthcare Transparency Initiative through the Arkansas Biosciences Institute. And for student and faculty access, these data are available free of charge. You need to contact Dr. Bobby McGee. His email's in the directory. There is a data request process. You put in your information, your aims, your project description, the types of data you want access to. You submit it. There's a short approval process. And then once approved, you can get access to the data. If you are not part of UAMS, then there is a data request process on the website. If you go to arkansasapcd.net and click, there's a big button that says how to request data, then that will take you through it. Or you can reach out to us, the email that Sarah shared, and at the end of this session, we'll provide other links for you to contact us. And then you can go through that process. That process does, when it's outside UAMS, there are charges that are incurred. And so, and the last part of your question, also from a provider standpoint, how can organizations like Arkansas Urology use APCD data to benchmark their cost and utilization against statewide averages? The most important thing to remember, if you are going to access these data, the information produced by your project must in some way benefit the health of Arkansans. So these data are not to be used for market analysis to see if your prices and your utilization is more or less or whatever. But, you know, the information like that can be gleaned in many, many ways. So if your particular focus will benefit Arkansas, the health of Arkansans, then it might be worth a try. The next question by Denise is, will the current legislative landscape around PBMs potentially change how the data is compiled? Maybe, couldn't give you any specifics. The legislation that manages the HTI Act 1233 has pretty broad arms and requirements around what data. If you are a health insurance carrier, whether a PBM, a TPA, or fully insured in Arkansas, these rules apply to you. So I don't know if by compiled you mean collected by us in the APCD, probably not. If you mean what data, how the data is used ultimately, how carriers use PBM data against other things, It may change, I don't know, but I will tell you what, we will take that as a subject for a future data users group. How about that? That's a good question. Okay. Again, if you have more questions, feel free to reach out via email. That'd be great. So the next topic we're going to talk about is the member enrollment selection table enhancement, or MEST. We're going to call it MEST. We introduced MEST back in July of 24. And it's an analytic data set of sorts, and it allows data users to easily segment and identify qualified study populations by member enrollment, payer type, month, and or year. So I believe that a picture speaks 1,000 words, so let's look at a picture. Right now in our enrollment data, if you've looked at it at all, there is a row per segment, and by segment, we talk about the time a person is covered by a particular policy. And in this example, this submitter happens to be Humana. It's a bit made up, but this is a real submitter. This is the member ID. This is the study ID. These two right here, Sarah described what that means. The ME998 was gender. And this particular individual has data from 2 different payer types, commercial and Medicare Advantage, different products, and then different enrollment dates. And if you look here, in this plan, the member began enrollment, coverage began in 2015, July of 2015, and then ended in July of 2016. The second one, the enrollment began in September of 2016 and ended in December of 2017. This asterisk means that the MEST table is from data 2016 forward, and some of our enrollment goes beyond that. But in this case, what I'm about to show you, this date would default forward to January 1st, 2016, so that it could still be used in the MEST table. All right, so 2 rows, lots of months, and even then it's hard to know what's what. So let's take a look. So what we did is we broke it out into these distilled fields that will help you see when this person was covered, what month, etc. So remember, this first one was the COM, and it had begun in 2015. Well, that doesn't count, so we changed that to January 1st, 2016, and it ended in July of 2016. So he was covered for 7 months, and the enrollment string, each character in this enrollment string represents a month. So January through July. His other plan began in September of 2016 and ended in December of 2017. So 4 months in 2016, September, October, November, December, and all 12 months of 2017. And what this allows you to do, the MEST file was intended to help users identify continuous coverage, breaks in coverage, and overlapping coverage. So there's no overlapping coverage in this example, but there is a break in coverage for 2 months here. In 2016, this person didn't have coverage. That could be important to your study question. So this slide details that a little bit more, what I just described. And I left it in here from the original release of this data set because it's easy to describe and visualize how the enrollment stream works. So we'll just move on from there. So what's new? Why did we need to enhance it? Well, MEST allows the data user to identify continuous coverage, gaps in coverage, and overlapping coverage. It lacked the ability to know if the member was covered under medical, pharmacy, and or dental in the enrollment period. And the first user that used this MEST data last year he struggled because of that lack of information. And there are 3 fields on the enrollment member record, ME01, you can see them here, ME018, 19, and 20, and those flags represent for that plan, that enrollment, if that member had medical and or pharmacy and or dental coverage. Because some plans have all three, some plans just have two, some plans just have one. And there was a way to take your MEST record and go back to the enrollment data and do a bunch of coding and things to get it, but it was so hard and it really did impact the deliverable that this particular user had. So what we did was we fixed it. So we have added this information to the MEST record. So we have now 3 new fields. These indicators, the value 1 represents that the member was enrolled in that type of coverage for that year and months indicated, and if it's a 0, they weren't covered. But again, a picture speaks 1,000 words. So let's look at an example. So the top part of this are enrollment records. And there you can see the examples are differentiated but in purple and green. So let's look at the purple. So this particular person, in this case, it doesn't matter really yet if they're calm at this point. This particular person, MEO20 is dental coverage, had dental coverage from January 2018 to June 2018. And then again in September 2018 through December 2018. So with this, let's go down and look at what that looks like. So there's one more. Here's the dental coverage flag. And we've already learned how to use our enrollment string. So this person was covered in this period of time. It's pretty easy to see up here that there was a gap in coverage. July and August, they didn't have dental coverage, but it's illustrated here. So the next thing this person had was pharmacy coverage, MEO19, and medical coverage, MEO18, from January 2018 to December 2018. And that is illustrated down here, that this person had 12 months, all of 2018, medical and pharmacy coverage. I want to tell you, make you aware that this is pretty cut and dry. We have a record per coverage type, right? There's a record for dental, there's a record for pharmacy, there's a record for medical. Not all carriers submit data this way. This particular carrier at one point couldn't give me a combined record. They couldn't give me one record with all the flags. Even in this case, where medical and pharmacy had the exact same enrollment period. So they had to give me 2 records. That's like this, but we were able to roll it all up so it looks like this. And the next example, we have coverage in 2019. They all 3 began in February and ended in 2020, December of 2020. And again, you see the coverage types broken up, and it rolled up to 2020, all 12 months, had all 3. And in 2019, only the February through December had all 3. Let's look at another one. Okay. In the enrollment records, the top enrollment record is from December 14th to November 15. And this person, this particular carrier, could roll their 2 coverage types up into a single one. So this person had coverage for medical and pharmacy in this period. And in 2018 to 2019, they had medical and dental. And in 2019 to 2020, they had medical and pharmacy. So I put an X here because this is all before 2016. So we didn't build a MEST record for it. In this case, this in the purple, this person had coverage 1 month in 2018 and 11 months in 2019 for dental and medical. I almost missed that right there. And so this is the row. And 2019, all like this. And then the green example, similar. So December 2019 through November 2020, and the blue pharmacy and the blue Yeah, 1 month in 2019 and all months 2020. So with this, you can use this to help find your study population. And you will know if they had coverage at that time. And that really was the question that our user was trying to answer. I see that maybe they were enrolled during this time, but did they have medical coverage? Did they have pharmacy coverage? And did they have dental coverage? This will help it. So with that said, this file, it's in its final stages of documentation and packaging and testing, and it'll be ready in January 26th. The way to acquire it is the same as before. You just need to go to the Arkansas APCD website. The data request steps are found here. This will be a link in the deck when you get it. And to look for more information about MEST when we get the documentation updated in the upcoming data tips emails. And if you don't get the data tips emails, let me know. All right. It is 12:58 and our session ends at 1. So I'm going to use the final 2 minutes we always have this slide. This will help you get quick information about the data that's available to you right now, when the next data will be available, some highlighted data tips and issues. If you're on our data tip email, you probably got these earlier in the month. Always check your data tips. We'll say it again and again. Send any questions, requests, whatever to this link or the email that Sarah provided. Please send us ideas for future data users groups. We got one today. Thank you very much. And then our next session is in January 26th. I did that in 1 minute. So thank you very much. It was a pretty dense agenda today, but you got a lot of information. We're going to make certain that the scripts are available and the recording and the slides. So look for an email thereafter. And
Hey.
oh, one more.
Hey, Kinley, yeah, there's 2 questions.
Okay. Okay, great. Thank you, Ashley. The first question is, queries using ME998 and composite keys like concat take several minutes or hours to complete. For linking 100 data points from birth certificate to claims and pulling in took about 45. Is there any way to do that? If you're using the UAMS version of this from ABI, the primary problem is that the infrastructure you're working on is very, very slow. So maybe we could talk offline, but this is not an unfamiliar complaint from users of the ABI subscription.
You say too that if you're pulling claims is kind of always going to take a long time. But when you do pull claims, make sure you're not using a join at the same time. And if you need to like define your population, do it using like an inline statement. Because that'll make it a lot quicker than if you're trying to join. And that's why in my part I said to add your study ID and stuff after you pull claims, because if you're trying to do it at the same time, it's going to slow it way down.
Thank you very much, Sarah. Admittedly, I'm not a big SAS user, so thank you very, very much. Happy to talk about it more though offline. And the second question is Medicaid QHP the same as private option? Yes. Do you suggest the exact fill date match? Is it possible to see small variations in fill dates, even if there are duplicate prescriptions? It's been my experience, no, Sarah. What about you?
So yes, when you're looking for duplicate claims, you do want to use the exact fill date match. You don't really want to include claims that are almost duplicates. As far as those 4 variables, you want all those 4 variables to match exactly.
Yeah. What were the fill date for pharmacy?
Pharmacy, MPI,
MPI and drug
drug code, and then study ID, I think.
Yeah. Yep. Okay. Thank you. Great questions. And I will release you all and look for an email with information about this deck and session. Have a great day.